Well, we're in the midst of a dramatic transformation in our healthcare system. To start with, previously unimagined numbers of people are growing to be very, very old in America. And we need to develop the capabilities to provide the special care that they require. Many of them have chronic diseases. Many of them have several chronic diseases. They're on multiple medications. They're frail. They require care to be provided not in a hospital or a doctor's office, but in another setting, often in the community or even in their home. In addition, the way care is being delivered is changing. Care is being delivered in teams, which are interdisciplinary and interprofessional. It's being delivered by phone. It's being delivered by teleconference. And it's relying increasingly on communication between members of the healthcare team, rather than one individual keeping everything in his or her head. In the midst of these changes, we have the Affordable Care Act, which has delivered at least so far 10 million more insured people requiring care. And at the same time, we have a very significant growing deficiency in the number of primary care providers. It's estimated that we're 45,000 short right now, and we'll be 60,000 short if the current trends continue. The combination of providing many more people with insurance, which is a very good thing, and having this tremendous deficit in the number of primary care providers really adds up to a very hollow promise. What good is it to give somebody access to health insurance if they don't have access to health care? In order to close that gap, we have to try to develop more primary care physicians. It's been difficult for a variety of reasons. We need to have new models of care which are more efficient and more effective, so that more individuals can be taken care of in any given setting or by any given group than previously. And there are ways to do that, particularly with electronic medical records, which are very helpful. And thirdly, we need to make sure that all healthcare providers who are fully trained and fully competent to provide primary care are permitted to practice, as we say, at the top of their license. And that is when the discussion starts to talk about nursing. Nursing is the largest, 3 million strong, and most respected component of the United States healthcare system. And with respect to primary care, it's been well shown, documented repeatedly, and supported by the National Academy of Sciences that advanced practice nurses are capable of providing core primary care services as safely and as effectively as physicians. They can't do heart transplants. They don't do brain surgery, but core primary care services. And in fact, many physicians welcome this because they would rather spend their time on the more complex cases and patients. And so a partnership between physicians and nurses that gives the nurses opportunity to provide the core primary care services and work with physicians who are taking care of other problems that arise in the patient population seems to be one of the principal approaches that we're going to have to adopt in the United States if we are to have an effective, safe, timely healthcare system. The movement to have advanced practice nurses, and in many cases those even with further training to have a clinically oriented doctoral degree, bear more responsibility for patients, to give them the opportunity to diagnose and to treat patients independently, to provide them with the opportunity to hospitalize patients and oversee the care. That movement started here at the Columbia University School of Nursing. And the school has continued to play a leadership role in the profession's advancement toward a redesign, a re-engineering of what it means to be a nurse in America. That has attracted, at the same time, a remarkably selected group of individuals as students who see this institution as a critical thought leader and change agent in American nursing. At the same time, that's attracted and retained a group of faculty who are authentic scholars in the practice of medicine and understanding the needs of patients. And these individuals, while they have technical knowledge and expertise, also have a caring approach which has become emblematic of the Columbia School of Nursing. It was said many years ago by a physician in Boston that the secret to taking care of a patient is to care about the patient. And I think that for me, has always characterized Columbia Nursing. At a time when nursing is changing, and in fact, it's a stressful time for nursing because these changes mean increasing demands on nursing. At the same time, what we teach students and the way we teach it is changing. There's a new pedagogy in healthcare, in medical schools, in schools of public health, in dental schools, and certainly in nursing schools, because the change is probably greatest there. If you are to effectively deliver that new pedagogy, that new curriculum, you need a proper environment. You need the facilities that have to be designed not necessarily just to look good, but to work. And if you have an archaic design for the environment, it's an impediment to the effectiveness of the kind of teaching. Simple things like how big should the classrooms be? The days of the large lectures and lecture halls are over. And it's not so easy to say, well, let's just take those big lecture halls and chop them up into a bunch of small rooms, because you know what? Most of them aren't level. They're slanted. So you can't do that. I mean, just simple things like that. But it goes far beyond that. It includes, obviously, a lot of information and computerization and making things available in a variety of ways, in a variety of settings, at a variety of times. Libraries don't have any books anymore. The whole environment for the educational process is changing. And I think it's really exciting that the Columbia School of Nursing has at exactly this time, when the demands are changing and accelerating and when the practice of nursing is transforming, that have the opportunity to create an environment which could also represent a leading environment in the United States for the education of nurses. So not only is it that we're leading in terms of the profession, but we're leading in terms of how to create the next generation. Well, I see this as a really special opportunity. A special aspect of it is not only the timing of the changes in healthcare, but the widely recognized and continuing leadership position of this particular school. The changes in the curriculum and the way it is delivered to the students and how learning occurs. To have those three things occurring at once is very exciting, and what it really means is that the likelihood of having an impact is much greater here than anywhere I can imagine. I can imagine a good nursing school that's not in a leadership position in terms of professional re-engineering and just wants a new building. And I can imagine one that might be thinking very hard about how to change the practice of nursing, but doesn't have a chance to build a new home for the education. To have those things happening here, from my point of view, is a good investment. It's maybe a great investment. Donors think about what they're going to get for their gift. They think about, is this the best place to make this investment? An investment here leverages all these opportunities that have been created by what's gone before at the Columbia School of Nursing.
High fidelity simulation is an educational technology, about 20 years old, born in aviation. It allows us to do three principal tasks: to task train our students in real-time situations. Two, it allows them to do critical decision making without harming patients. And thirdly, it allows students to work in a broader team environment, multidisciplinary teams, where they get used to sort of the context, the ecosystem of the operating room. Today's scenario is based on the precepts of a crisis resource management, which was also born in aviation, in which we have an obstetrical patient who has experienced a seizure, an eclamptic seizure, which is part of a condition of pregnancy. This patient requires an emergency surgical intervention, a cesarean delivery, cesarean section. And so our students today will be participating in a simulation in which they will play roles of the team members and participate in both the emergency surgery and care of the baby once it's born. The first part of the scenario, we have a nurse summoning the obstetrician to the operating room suite in order to let him know what the condition is. The second part, the students, our anesthesia students, will be actually inducing general anesthesia, putting the patient to sleep in order to prepare her for the cesarean delivery, and then the surgical team will actually perform the operation. And then lastly, the baby, who certainly has been in non-optimal condition in utero, will have to require an intervention to be resuscitated. So each of our students is playing a different role in that team, and that occurs in real time. And requires them to perform all those tasks under real conditions. Well, a couple of things. The things that I had alluded to: operating in real time, replicating the real environment, clinical decision making without harming the patient, and then of course lastly functioning as a team member. But I think also it works on students' self-efficacy, their own ability to function clinically without the pressures of the clinical environment, although we recreate those. And also I think it provides the student with an opportunity for them to actually do hands-on, participate in the team, and sort of get a sense of how they would perform in rare events. Maybe you never care for a patient who's had an eclamptic seizure. And so we're able to train for emergencies that are rare, and hence you don't see them clinically. You may go through your entire training and never have a patient who actually seizes from a complication of pregnancy. And so they're able to manage that patient and do so in a way that's safe, but also exposes them to the critical thinking that's necessary. Simulation began in aviation in crew resource management. So the aviation industry created simulators of airplanes in which the pilots could be trained in both routine and in emergency conditions. It's part of their initial training, but it's also part of their ongoing training. It was, I think, Dr. Gaba at Stanford also brought that into anesthesia. So we borrowed their model of crew resource management training, built simulators that replicate the human being. They blink, they cry. We can manipulate the physiological parameters to create really any scenario we want. We can start IVs on them. And so it took off from there. I trained at Harvard at the Center for Simulation there, medical simulation there, and this is exactly what we did. Scenario development, actually how to do that, and then more importantly, the debriefing afterwards. We spent a great deal of time reflecting with the student on how things went, what they did well, what things could you improve, talking about how they communicate, how they did their decision making and so forth. So it's an extraordinarily good tool for instruction. It also allows us to point out gaps in students' knowledge, gaps in behaviors. There's a whole cluster of decision-making, or excuse me, non-technical skills that are important, how they communicate, their leadership skills, how they manage tasks, how they promote situational awareness in the room, and so we can actually do that, film that, reflect on that, and point that. Well, we're very excited. We have a new building coming. We have a 2-floor simulation lab, which will expand greatly the sort of footprint we have in the nursing program. I participated in the committee work with that throughout the process. We will have an operating theater, a labor and delivery room, a recovery room, an IC room, a large teaching room where we have our anesthesia machines. Other programs, ETP will have their labs. This is their entry to practice lab where they'll be able to have their simulation activities. There are exam rooms where our colleagues in pediatrics and in acute care can actually replicate the office environment, individual examination rooms, all of which is hardwired with technology where things can be filmed. They can be monitored from central locations or locations within the lab itself for the faculty to interact with these experiences. And of course, we'll have the technology to broadcast that afar, even into your office, even into an auditorium where we can have a larger audience to actually watch our activities. Another big priority for the dean was to make that visible. So much of our simulation center will be glass enclosed. So stakeholders, other students, people who are interested in donating to the program can actually walk by and watch the activities without interruption. Well, the dean appointed several faculty to this committee, and we interface with the physical plant folks who are actually doing the mortar and brick of this building, as well as our financial team who sort of, keeps an eye on what these things would cost. And we met regularly and frequently, first of all, talking about what our needs were for each curriculum, talking about the spaces that we have currently and how we would like to either continue or discontinue the type of operations that we have here. And then we drilled down more into other details, and that includes down to what kind of equipment we want, what things we want on the wall, what technology we want, where we want cameras. So it's a very complex undertaking from both the people who are in charge of building the physical plant, plus the human interface, the students and the faculty that would be using that. So it's been going on probably for about 18 months now, and we're in the final phases where actually things are being budgeted and things are being equipment's being bought and considered what we actually want to have there. There's beautiful renderings that the computers have done to give us an idea, and it was amazing to see those renderings. When you actually see your thing visualized, it's quite remarkable. So we're very excited about that. So the obstetrician is being summoned to the delivery room for a patient who's experienced an eclamptic seizure. The labor and delivery nurse is informing the doctor the condition of the patient. The anesthesia team is being summoned, and they're preparing to do a general anesthetic for this patient. The anesthesia team pre-oxygenates and renders the patient unconscious, secures the airway so the surgical case can begin. Once anesthesia is ready, the surgical team begins the procedure. Incision is made. The various surgical technicalities are done. The baby is removed from the mother and handed to the neonatal team. At that time, the baby, because of the mother's seizure and her preconditions, the baby is heart rate is 60 and the baby is not breathing. The neonatal team is now resuscitating the baby. They manually ventilate the baby with oxygen, and they perform chest compressions, CPR. Fortunately for the baby, the care was such a degree that the baby... So the neonatal team resuscitates the baby, providing CPR and assisted breathing, and the baby wakens up and begins to breathe and spontaneously cry.
So what we try to reproduce in a sim lab is to produce a real life setting of what the students are going to experience once they get to their clinical environment. We try to replicate every fine detail of technology coupled with medical equipment, coupled with real life situations, and we bring it to our sim lab. In this way, the student can actually learn from their mistakes. They could learn from the environment. At the same time, it's controlled without causing any harm to the patient. Absolutely. So one of the mainstream ideas of simulation training is to keep it as real as it possibly can get. And we do this by incorporating various distractors.
What are distractors?
Actually, the Institute of Medicine's report actually suggests that distractors or interruptions are commonplace in busy hospitals, and they can actually be fatal. So what we do is we create these distractors where I'm asking anesthesia, for example, lower the table, raise the table, give PIT, something not directly related to that clinical focus, whereby the participant of the simulation scenario can actually get distracted and keep them away from the mainstream scenario and what they're supposed to be focusing on. And this just helps to enhance their learning experience. When I first experienced a sim lab, I remember we were exposed to a trauma situation where a bus crashed on the side of a road in Pennsylvania. And what they did is they gave each and every one of us a role in that trauma. And as soon as that, I thought it was very chaotic and it was very real life. They had moulage, which is the type of makeup that we incorporate in a simulation lab. And I just thought, one, it was very scary, but it was very realistic because there was that level of frustration because you didn't have necessarily all that equipment that we have in a hospital in a controlled environment. So it actually made it that much more real because you thought in a classroom, yes, you would have every key piece of equipment that's needed to adequately take care of that patient. But we didn't have that, which made it, wow, this is real life. This is it. This is state-of-the-art, innovative teaching strategy that really enhanced my experience. I think that's exactly where we are going as educators. We certainly are advancing towards simulation because we are realizing that students are actually gaining, if not the same, but better experience per se in a simulation lab than in a real life clinical situation. We have a controlled environment where we could really see what the student's level of thinking was. Why did you do that? Where in a clinical situation, we may not be able to really see our student interact in the way that they did that we can sit back and watch in a simulation lab. So we're certainly moving forward toward that area.
And then
We will be in an innovative setting. We will have the state-of-the-art equipment that we need. That state-of-the-art equipment is for tools for us educators to help move healthcare forward. So we're certainly looking forward to having those tools that we could work with. That's certainly going to provide an extra tool that we as educators are going to be able to use to help enhance our students' learning experience. And from that, we're going to be able to move healthcare forward.
Well, we are doing some very creative and innovative and exciting things here at Columbia Nursing, and we think it's going to make a big difference in the future of healthcare. So we excel at clinical education, advanced practice nursing, and our research and education as for PhD students. And we attract students who are interested and aspire to clinical practice at the highest level. That's our clinical doctorate. And we attract students who want to change the nature of healthcare through research and education. And I think as a testament to that, this year we had the highest enrollment in our entry into practice program in the history of our school. So I think that tells us that what we're doing and how we're doing it is the right thing. Well, I can sort of give you an idea what our after our students are no longer students, what they're doing. So we have alumni who are nurse informaticists working on diagnostics and the way to use data to understand clinical decision making. It's a new field in nursing, and we have nurse scientists who are doing that have graduated here. We have executives in health systems that have gone through our program and understand health policy because that's one of our strengths here. We have independent clinicians, nurse practitioners who are working in all parts of the country. We have nurse anesthetists who are working in the large medical centers providing anesthesia. We have pediatric nurse practitioners, behavioral health nurse practitioners, adult, acute, family, the whole range of nurse practitioners. And they're all over the country, and they're doing marvelous work, high quality, cost-effective care. Well, if you look at the healthcare environment today, it's much more complex than it ever was before in a number of ways. First of all, the use of technology is huge in healthcare. So nurses need to understand how to practice with technology and how to manage that technology. So there's that. It's also that patients are sicker. If they're not sick, they wouldn't be in the hospital. So especially in terms of chronic disease. So the prevalence of chronic disease in the U.S. is very high, and so those kinds of clinical issues our nurses are dealing with. So they are practicing both within hospital systems, managing very intensive care throughout the hospital with a variety of kinds of patients, from babies to the elderly, in all services in the hospital. So providing really advanced clinical practice skills. But they're also in the community. They're also in the community doing what we call population health, which is really trying to understand how people stay well and what in their environment causes illness, and really tries to manage that in a community, in a state, in a region. So our nurses are there. They're in education. I mean, we provide a lot of faculty throughout the U.S. through our PhD program. They're doing research. So they're doing research in infection control and chronic disease, health systems management, and many fields. So that kind of gives you an idea of the breadth and the quality of what our nurses do. So our reach into global health is much greater than it used to be. It's a new area of innovation for us. We're doing a couple of different things. We have a new global institute, an Office of Global Health. We're a World Health Organization collaborating center for advanced practice. We have partners in all parts of the country. Columbia has global centers in 8 countries throughout the nation, and we are now doing research in 3 of those countries, mostly around education of nurses in other countries, and also about what their research interests and needs are in other countries, because we have expertise in there. We have nurses who have done research in a number of countries, and so this collaboration we're developing with nurse leaders globally is very, very exciting. It's one of the newer things that we're doing. Yeah, well, the great thing about our students, first of all, they're post-baccalaureate students, because our educational program is at the graduate level. So these are people that have done a remarkable range of from being actors to scientists to chemists to lawyers. They've decided that they want to be nurses, and that change in career, that intentional decision to stop doing what they were doing and take on something new, and not only that, but go back to school into a graduate program to do it is quite remarkable. So when we get them, they know they want to be nurses, and they usually know why. So what we do is just educate them to really the science and the clinical component and the care component. We add that to an education they already have. So they are remarkable students. They're smart, and they're experienced, and they understand something about healthcare. That's why we invite them to join us. But they really are remarkable. Well, people have asked me. So we've been working on the idea for a new building for quite some time, and people have asked me, does a new building make really a difference in quality education? So we think that that's true. When we started out, we asked our students and we asked our faculty and our staff what kind of an environment would they want and what would make a difference for them. And they pretty much all talked about space that would allow for cooperation and collaboration on projects, whether that's developing a new curriculum or talking about a new course or team research, or students who want to either work individually on a project or work in teams with other students, but they wanted an opportunity to have a space that they could work together. They want a place to hang up their coat. They want light, and they really have inspired us for the kinds of spaces that they're going to have in this building. It's really remarkable.
How that's going to work?
Well, let's just start at the bottom of the building, because that's one of the most exciting spaces. That's really where you come in, and students will come in, community people come in, our partners on the whole campus comes in, and it will be this gorgeous big open space where students can be. We have a cafe there, so students said they wanted a place to eat, so they'll have a place to eat. It'll have conference space, so we can have meetings and have community meetings in there. And that's also where all the offices that students need in the beginning. That's where financial aid is, that's where they get admitted, that's where their advisors are and where their mentors are and where other students gather. So from the very beginning in the building, it's designed to invite you in. And then the next 2 floors are simulation space, which is, we're just very excited about that. That's really the preclinical training for all this high technology, and we can simulate just about every patient experience, from operating room, emergency department, labor and delivery, exam rooms, behavioral health rooms. We can simulate just about anything. So when they get into the clinical environment, they're safe. So that's 2 floors. And then you get our faculty offices and our research space and our student space, the PhDs and the clinical doctorates, where they can have their own spaces to do their research, computer technology and all of that. And then the 7th floor is going to be this glorious terrace with a big event space and trees and flowers, and it's just marvelous with a view of a great view of Upper Manhattan. So when you put it all together and you sort of take a trip through the building, there's really something for everybody in there. Well, I'm pretty excited. I've been waiting a while. and I'm going to have to wait a while longer, but yeah, I'm pretty excited about it. Well, our alums are really the exemplars of what we do here. And if you meet with our alums that were educated here in the 40s, of which we still have many, you begin to understand what nursing was like in the 40s. And you can just step through time and see how nursing has advanced as a profession, has advanced as a science, and has really advanced as change agents and leaders. Our alums are the story about that. So they remind us of, we think we're very high quality and we're really doing all the innovation now, but they remind us that it's always been that way. And I think for them, having a space where they can feel a part of this environment, which is pretty hard to do now with our space, I think that's really what's in it. There are guides for the future, because they've been living it, so they're a real partner in this. Well, we want to paint a picture of really sort of the connection between the population that they'll serve and what the need is there, the places that individuals seek care, and their role in making that the best possible experience for patients. So one of the major goals through the health reform is to improve the patient experience. And all of us think a lot about, what does that mean? What does that mean for people? I don't know any profession better, now my colleagues may argue about this, but any profession who is better prepared to find out from individuals what their experience is like. Not only what their experience is like when they're ill, but how their illness affects their work, their kids, their family, where they live, their partners. That's something that we do pretty well. So if I can get potential students to understand that connection that we have with people, helping them long term, I think that will inspire them to want to come here. Well, Americans have placed their trust in nursing. We knew that. We know that from media reports and surveys that have been done, that they trust nurses. But we want people to understand why that's true. We don't want it to just be a slogan. We want people to really understand why nurses are trustworthy, not only because they're expert clinicians, particularly if they're a Columbia nurse, but they also understand environments, and they understand health systems, and they understand technology, and they're just exquisite providers of care. And I think that trust, we want to earn that trust. We know that it's true, but we want to earn it. So I think what we might say to the American people is, if you experience a Columbia nurse, you understand that trust. We think we're the future of healthcare, and we think that Columbia is the future of nursing. We believe the future of healthcare is nursing, and we believe Columbia is the future of nursing.